Good evening, everybody. Thanks so much for joining us. Please stand by and we'll get started in just a couple minutes. Okay, good evening, everybody, and thank you so much for joining our Men's Health webinar. We're so grateful to have the opportunity to share important men's health education with this group tonight. My name is Amanda, and I'm the host of our event. I'll start with just a couple quick housekeeping items, and then I'll introduce tonight's speaker. Most importantly, your participation is completely anonymous to other attendees. No one can see your face or your name, and any questions that you ask will only be seen by myself and our speaker. We encourage interactive presentations, so if you'd like to ask a question, please type it in the chat box at the lower portion of your screen, and we'll save time at the end of the presentation to answer as many as we can. Our webinar tonight will be presented by Dr. Chris Powell, a urologist and men's health specialist at West Georgia Urology. He specializes in treating a broad range of urologic conditions, and we are very fortunate to have his unique skill set right here in our community. Dr. Powell, I know your time is in high demand, and I thank you for your willingness to be with us this evening and share education with this group. So I will turn it over to you to get us started.
Okay, thanks, Amanda. Thank you for having me, and thanks for everybody for taking time out of their day to attend this webinar. And hopefully we've got some interesting information for you. And again, like Amanda said, I'm happy to answer questions at the end of it. So I'm going to get started. I'm a part of West Georgia Urology. I've been here for about 7 years now. We're located in several locations. Our primary office is in Carrollton, but we also have locations in Villa Rica as well. I did most of my education here in Georgia. I went to Valdosta State in the Medical College of Georgia, and I trained 5 years at the University of Kansas for my urology residency. So we're going to go ahead and get started. We're going to first talk about what erectile dysfunction is. We're going to define it. Simply put, it's the inability to achieve or maintain an erection that is satisfactory for sexual intercourse, and it's extremely common. It's a subject that not a lot of people are excited to talk about or are willing to be open about, but in my line of work, I see it all day long, and I could probably see it more frequently if people were more willing to be open and admit it and talk about it and seek treatment. How common is it? It's present in about 40% of men at the age of 40, and that increases obviously as you get older, 70% in men age 70. And there are lots of studies that show it's very, very prevalent, probably more prevalent, like I said, than people want to admit. The erection process is simply nerves and blood flow. This picture does a good job of showing the blood flow to the penis and what the cause of an erection is. Those two oval structures in the middle there are called the corpora cavernosum. The one at the bottom there is the urethra, the tube that you pee through. But when the cavernosum fill with blood, the arteries dilate and they fill with blood. And then that dilation compresses the veins, which are on the outside there, the blue veins on the outside. And those compressed veins don't allow blood to exit the penis. And so that's what allows you to have an erection and maintain an erection. In fact, not very common cause of erectile dysfunction is something called venous leak, where those veins don't compress appropriately, and so you can achieve an erection, but then you lose it very quickly. But this picture just does a good job of illustrating the corpora cavernosum, which we'll talk about in more detail later on. So that's the primary blood flow to the penis and the cause of an erection there. There are lots of causes of erectile dysfunction, lots of comorbidities associated with ED. I think most patients probably have a combination of these. It is somewhat uncommon for folks to have just one single issue causing erectile dysfunction. Lots of medications can cause erectile dysfunction. Certainly diabetes can cause erectile dysfunction, both from a blood flow issue and from a nerve standpoint. Vascular issues by themselves obviously cause erectile dysfunction because the vast majority of an erection is just good blood flow. And then there are less common, but certainly other issues that are associated with erectile dysfunction, such as pelvic surgery or maybe significant spinal cord disease or endocrine problems. But again, most patients that I see have multiple reasons to have ED. Regarding specifically diabetes, there was a census in 2015 that showed that 15.3 million American men had diabetes. I'm sure that number is much higher now. Like we talked about earlier, diabetes affects erections both from a neurological standpoint and from a blood flow standpoint. And so these patients see less benefit with oral medication, not zero benefit, but certainly less benefit. Their erections or their ED tends to be more severe and associated with a decreased quality of life. And occasionally, more so in cardiac disease, but occasionally in diabetes, ED can be the symptom that causes patients to explore, I guess, causes of ED, and then sometimes that leads to a diagnosis of diabetes. That can be kind of the initial finding. Like we talked about earlier, ED pills require stimulation, so healthy nerves and healthy blood vessels. And if these are damaged to diabetes, which they often are, oral medication may not be quite as effective for patients with diabetes. Very strong link between erectile dysfunction and heart disease. And in fact, if I see a really young patient in their 20s or early 30s that have erectile dysfunction, oftentimes I'll have them see a cardiologist before we get too involved treating their erectile dysfunction, because occasionally early erectile dysfunction will be an indicator of early onset heart disease or maybe a congenital issue or something like that. But very common for folks who have erectile dysfunction to have heart disease. And the reason for that is that the penile arteries are much smaller than the arteries supplying blood to the heart. So that's the reason that ED oftentimes comes first. It oftentimes comes before any sort of cardiac issues, and can be a sign that maybe need to start looking into vascular health. But in general, penile arteries are about half the size of the vessels that are supplying blood to the heart, and much smaller than internal carotid arteries, which can also become stenosed or obstructed. So certainly if you're at that point, you probably have had ED for a while. ED is also associated with prostate cancer treatments. We do prostatectomies here at West Georgia Urology, robotic prostatectomies. And I would tell you that everyone that has a robotic prostatectomy, even if they have a nerve-sparing approach, which is where you try to peel those nerves, the yellow structures there, off of the prostate, and you try and save the nerves, even if you have a nerve-sparing approach to your prostatectomy, there will be significant issues with erectile dysfunction. Some of that might get better over time, and it may not. Depends on kind of your baseline ED and your baseline quality of erection and the other comorbidities that we discussed earlier. And then some patients have such significant prostate cancer that we're not able to spare the nerves. We have to do a wider dissection and have to take the nerves, if you see in that picture to the right, have to take the nerves with the prostate in order to make sure we get all the cancer. And when that happens, medications they're not going to work. You don't have the nerve supply to get an erection. So like we just discussed, sexual dysfunction after radical prostatectomy affects 25 to 75% of men. I would tell you it's 100% of men initially, and then certain men, depending on the type of surgery they had, will get better over time. But even if you do a nerve-sparing robotic surgery, ED might be present for a year or more after surgery. And even if you say, well, I'm not going to have surgery, I'm going to go have radiation, up to 50% of those patients will also have sexual dysfunction. So if you have prostate cancer, you're probably going to have some form of ED or sexual dysfunction, no matter what treatment you choose. Low testosterone can be associated with erectile dysfunction as well. Oftentimes I'll tell patients that low testosterone is more impactful on their libido, and they'll have a low libido And because there is certainly a mental component to erections as well, that decreased libido will result in decreased erection ability. There's a lot of overlap in the causes of, or the comorbidities associated with ED and low testosterone, obesity, diabetes, high blood pressure, high cholesterol, those types of things. Low testosterone, also talked about a lot online and on television, very common. 40% of men around the age of 45 will have low testosterone, and that, like ED, that risk increases as you get older. Peyronie's disease is another disease or disorder of the penis. It can be associated with erectile dysfunction as well. It's essentially a plaque or almost like scar tissue that occurs most of the time spontaneously. There are lots of assumptions as to why it might happen or perhaps causes, but the truth is, for most guys, don't really have a good idea as to why it happened, and there's not a specific inciting event that causes them to have scar tissue or a Peyronie's plaque. And what happens with Peyronie's is you get this hard scar tissue that prevents the penis from expanding like it's supposed to, and so you'll get a curvature that can be significant, that can prevent you from having penetrative intercourse. And also, it can affect the blood supply, both the arteries and the veins, that can make having an erection much more difficult. So sometimes guys with Peyronie's will have a good erection up to the level of the plaque, and then beyond the plaque, towards the head of the penis there, they'll have no erection. So Peyronie's can significantly impact folks' erection. Sometimes we'll treat Peyronie's just by itself. If you have a good erection, but you just have a curvature from the Peyronie's, you can treat just that plaque and make things better. But oftentimes, patients will have ED associated with their Peyronie's. And in that situation, even if we get rid of the plaque and straighten the penis out, if you couldn't get a good erection at baseline, just making the penis straight will not give you a good erection. So sometimes you have to look at more involved treatment options to treat both the curvature and the actual underlying erection problem. So there are some alternative treatments. I'm not going to talk about these in great detail tonight. I don't personally do any of these. The AUA, which is our kind of national educational governing body, says these should be considered investigational. Oftentimes investigation, I don't want to get too far into this, but oftentimes investigational means a lot of cash payment up front, and without great results, at least on a national large study scale. Some of those options, which you may have seen online or on TV, include shockwave therapy, which we certainly do shockwave therapy for kidney stones and things where it's widely accepted, but not for this. Stem cell therapy, platelet-rich plasma, those types of things are still considered investigational. All right, so other treatment options that you might be more familiar with and that we routinely use are listed here. And I'm going to go into detail on all of these and tell you a little bit about the pros and cons of each. And again, answer any questions at the end that you have about these. Okay, so oral medications, by far the most common treatment option for ED. This is what you see on TV and online a great deal. A lot of startup companies in the last few years trying to take advantage of prescribing these medications and the prevalence of ED. So we're talking about Viagra and Cialis, Levitra, things like that. They work fairly well for early ED for patients that maybe don't have diabetes, or maybe they just have a little bit of erectile dysfunction. Maybe they're not quite as firm as they used to be, or they can't maintain erection quite as long as they could previously. And so they're kind of okay, but they would like to perform a little bit better. This is a great option for those guys. A lot of the side effects come from it being a pill, and when you ingest a pill like that, it goes throughout your whole body, so not just the penis. And we spoke earlier about what an erection is. It's basically good blood flow, and so these medications dilate the penile arteries, so they open those penile arteries up, increasing the blood flow to the penis and giving you a better erection. Obviously, you have to have some baseline ability for these medications to work. But the side effects come from that same blood vessel dilation effect working in other places in the body. So you can get low blood pressure, you can get flushing, headaches, nasal congestion, things like that are basically blood vessels dilating in places that you might not have desired with that pill. Um, so most of the time, patients of mine that stop medications, I'll have some that stop because of the side effects, because they're quite bothersome. A lot of patients stop because they just don't work after a while, or they don't, maybe they've waited so long that they don't work very well at the beginning. But uh, a lack of efficacy or significant side effects are the main reasons that people stop these medications. And then as far as some special precautions with these medications, a lot of patients that have erectile dysfunction have issues with their heart. They may be on nitrates. You cannot take an oral ED medication and nitrate at the same time. Nitrate dilates the blood vessels as well. These medications, as we talked about, dilate blood vessels, and so you can have a significant and dangerous drop in your blood pressure, and sometimes even passing out. So very important to know that it can interact with other medications and other conditions. Again, at the bottom of the screen there, like we talked about earlier, men with diabetes are 2 times as likely to move on to other treatments. Okay, intracavernosal injections, we're talking mostly about a medication called Trimix. It is essentially an injection into the corpora cavernosum of a medication that dilates those arteries. So again, the same concept, we're trying to increase blood flow in the penis, we're trying to increase blood flow to those penile arteries. You can see on the right side of the screen there, that's a needle going right into the corpora. It's a relatively small needle, it's a relatively small injection amount, but there's no way around it. You do have to stick it into the corpora. Fortunately, there's some cross connectivity between the 2 corpora, and so you just have to stick it in one side and that medication will go over to the other. It works in about 3 to 5 minutes. It works fairly well for patients that have the systemic side effects from the pills, like headache and flushing and things like that. The most common issues or common reasons that my patients that I've seen discontinue this medication is because it's uncomfortable. The injection itself is not too bad, but I think over time people just get tired of it. They get tired of having to inject themselves. They get tired of kind of a vague discomfort afterwards. Maybe they hit a blood vessel one time and they had a little bit of bleeding and that scared them. Sometimes this can be pretty intimidating for partners, for spouses. I've had some guys say that they would be willing to try it, but the needle makes their partner nervous. So it works relatively well. You do have to be very careful with this. It's relatively easy, or it's possible to overdo it on this medication. I think a lot of the kind of the common phrase that you hear on commercials for the pills, if you have an erection that lasts longer than 4 hours, call your doctor, that kind of thing. If you have pretty significant ED, I would tell you that that's rare when it comes to patients of mine that take pills. But this is actually something that you can overdo. You can inject too much of this and have a real significant possibility of having an erection a painful erection that won't go away, that has to be, treated in an emergent fashion. Okay. Moving on to vacuum erection devices. This is a relatively inexpensive option. Pain or discomfort is the reason that most of my patients discontinue this, but these are widely available. It used to be that it was really, you could only get it through your insurance company, but now you can get them online a lot of different places. You have to be careful about how much vacuum that you use. There are some electric ones and there's some manual pump ones, but you can overdo it in these too, and you can it cause some bruising or some blood vessel ruptures, something called petechia, which is where you get those kind of red dots on the skin. That's from these kind of micro ruptures. And if you don't have good erections at baseline, which is why you're using a vacuum erection device, what you have to do with these is place the device over your penis. initiate the vacuum, whether it's manual or an electric one, that pulls blood into the penis. But then it will quickly leak out of there if you don't place a ring at the base of the penis to keep the blood in the penis. The issue with that, though, is that in order to have that ring tight enough to block blood flow from leaving the penis so in order to keep your erection, you have to have that ring tight enough that for a lot of patients, they describe that as being really uncomfortable, that it just has to be so tight that it's painful, and that obviously kind of kills the mood as well. So at the bottom, it says in one study, 86% of patients with radical prostatectomy patients decide to move on to other sexual aids. And I would say that that's true. I mean, if I have a patient that uses a vacuum erection device, I think that most of the time they're using it to supplement like a pill or something like that. Like the pills are okay, but they don't quite get them where they want to. And so they're trying to supplement. They're just trying to cobble together a reasonable treatment. But I would tell you, if you're at that point, you should probably, move on to something more helpful, maybe like an implant, like we're going to talk about if you're a reasonable candidate for it. All right, urethral suppositories. This is Muse. Again, it's still, all these are medications designed to dilate blood vessels and increase blood flow to the penis. I don't think I've personally prescribed this in the 7 years or so that I've been out of training, and I prescribed it a handful of times that I was in training. I don't think I ever had anybody come back and say that they wanted a refill on this medication. It's just pretty uncomfortable to try to put this urethral suppository. So you stick this device up to your urethra, out the tube that you pee through, and a lot of burning associated with that, a lot of burning during erections. The efficacy, I mean, it'd be one thing if it just gave you a really firm, long-lasting erection, but I don't think that it's any better, and probably not as good as some of the other things we've already talked about. So in my personal practice, I mean, I don't speak for all urologists, but I'll tell you in my personal practice and in my colleagues, and so I don't think that there's a lot of this used these days. All right, so penile implants work for essentially everybody. I mean, they work for almost everybody that the first options that we discussed, maybe they worked for a while, but now they no longer work. We'll talk about what makes you a good candidate or a bad candidate for a penile implant, but this is purely mechanical. So you don't need good working nerves. For an erection, you don't need good vascular system for your erection. This is just mechanical, and we'll get into all the details of that. But it's extremely effective. At 7 years, 94% of the devices that are put in are still working, still able to inflate it and deflate it. Again, we'll talk about all that. And the patient satisfaction rate is extremely high. The biggest issue with a penile implant, and the thing that I counsel my patients on probably the most aggressively, is this idea that it's kind of the end of the line, that in order to place the penile implant, those cylinders that you see on the right, those long cylinders, are placed into the corpora cavernosum, those structures that we keep talking about that fill up with blood. So if you place a penile implant and you, for whatever reason, later on were to change your mind and say, oh, I should have tried something else, or I wish I would have done this, there's no going back. You've replaced that tissue or displaced that tissue with these cylinders. And so I think a lot of people are probably slow to adopt a penile implant, and maybe they struggle with really poor erections despite using maybe a combination of pills and a vacuum erection device and things like that for years. Maybe they don't want to have a procedure, or they're intimidated by the cost or potential cost or things like that. And we'll get into all that again in a little bit. But I would tell you, if you're struggling with these other treatment options and we go through this and you seem like a good candidate, it will work. I mean, there's a high patient satisfaction, high partner satisfaction rate. So most common side effects or complications, I break these down personally into an immediate post-op and a long-term risk. Immediately post-op, we're predominantly talking about infection risk. There's about a 1 or 2% infection risk with this procedure. That is higher if you have very poorly controlled diabetes, and that's one of the things that might make you not a good candidate for a penile implant. But mostly, you're talking about surgical risks such as bleeding, which is very uncommon with this, pain, which is, there's some baseline pain, but severe pain with this is extremely uncommon. I don't think I've personally ever seen it. And the real concern immediately post-op is infection. But the implant has an antibiotic coating and things, and we do all kinds of things to try and minimize that risk. And so it's only about 1 or 2%. Long-term complications, you're really talking about device failure or mechanical failure. And you see at the bottom of the screen, like we talked about, that's relatively low risk. They tend to last for a long time. And if you were to have a device failure, let's say that you had 6, 7, 8, 10 years of good use of this, and for whatever reason it won't inflate or deflate anymore, it's a relatively straightforward procedure to remove the old device and put a new one in. All right, so there are lots of different, or there are 3 different kinds of penile implants. There's a 3-piece that I'll spend most of my time talking about. There's a 2-piece and a malleable. The vast majority of penile implants put in across the country, and that's true of my personal practice, is a 3-piece inflatable penile implant. Like we just said, it's the most implanted device. It has a built-in antibiotic coating, which lowers your risk of infection even further. Another thing that we do in West Georgia Urology is that we typically do these procedures with 2 surgeons in an attempt to expedite the surgery, because there are good studies that show that the longer the patient is on the table, the higher the risk of infection is. So we try to, within reason, obviously we're not rushing or anything like that, but within reason, we try to make it a short procedure, and that lowers your infection rate as well. So what makes it a 3-piece device? If you look on the right side of the screen there, there's that round reservoir, which is sitting up there near the bladder. That lies underneath your abdominal musculature. You shouldn't be able to see or feel that. That's where the fluid is when it's not in the cylinders giving you an erection. So when the penis is in a flaccid or deflated state, the fluid is in that reservoir, which is hidden from view, and you shouldn't be able to rub your abdomen and feel it. The second component of it are the cylinders. There are 2 cylinders there. You can see it better on the deflated penis image there, but those cylinders fill the corpus cavernosum that we've been talking about. And the third component of it is the pump, which we try to put in the very front of the scrotum in a position that's very easy to fill and access. It's right underneath the skin there, because that's what you have to use to inflate and deflate the device. It has a pump that you squeeze, and there's actually a video that'll show this in a second. You squeeze that pump and it inflates the penis, or inflates the cylinders where the fluid goes from the reservoir to the penis, and you have a firm erection. And then there's a button at the very top of that pump that you squeeze, and that allows the fluid to go back from the cylinders to the reservoir. Very helpful if patients can do this themselves. We have lots of sample devices, I guess, that you'd be able to see before your procedure. There's a pump that is sent home with you for you to be able to kind of see what is in the scrotum, for you to understand what's going on there. And it's helpful if patients can do this themselves. But I have had a couple of patients over the years that maybe for whatever reason they lost hand strength, or they lost dexterity, or over time they just weren't able to pump the device themselves, and their spouse or their partner has been able to do that for them. So one thing I try to encourage whenever we start talking about penile implants is, if you have a willing partner, that they come be a part of your consultation, and certainly come to the prosthesis activation appointment and things like that. Because I have had patients that initially might have been disappointed. They didn't feel like they were going to be able to use their device as frequently as they wanted to, or maybe lost the ability to control, to pump their device, and their spouse comes in, and I can teach them to do it, and it really makes the device more meaningful and useful. But these devices have been around for a long long time. Over 500,000 men have these, so very common. All right, here is the video. So this is going to show all three components. This the pump, so the fluid is going from the reservoir to the cylinders. Pump that a few times and you'll be able to feel. You see the cylinders are right at kind of the mid glands or mid head of the penis there. That's where they're supposed to be. And then that button on top, you squeeze that button, you'll hear kind of a click, or maybe not hear it, but you'll feel a click. You get used to the different things that tell you that it's working, but you'll be able to feel that click, and the fluid exits the cylinders and goes back into the reservoir. All right, so this is usually performed as an outpatient procedure. There's a small incision in between the penis and the scrotum, or just above the pubic bone. We're talking like a, an inch, inch and a half, 2 inches maybe at the most, but a very small incision. Generally, it takes a few days to return to your kind of regular routine of light activity. I do leave patients partially inflated, so not anything that you couldn't go out in public, but I leave a little bit of fluid in those cylinders to allow the healing to take place around a partially inflated cylinder. And the idea behind that is that you don't want the corpora cavernosum to scar down with the cylinders deflated, and then later on try to inflate those, but there's scar tissue preventing that. So for about 10 to 14 days, I leave patients at least a little bit partially inflated, and then they'll come to clinic. I'll deflate them all the way. And then 6 weeks after their procedure, they'll come back to clinic, and that's where I'll teach them. They'll be much more comfortable at that point. I'll teach the patient or the patient and their spouse to inflate and deflate the device. They'll what we call cycle it, so pump it up and deflate it several times in the office and make sure everybody feels very comfortable with it. And then after 6 weeks, you can use the device. So there's a lot of insurance coverage for ED treatment, particularly for penile prosthesis. The oral medications and things like that are harder to get covered, but certainly coverage could be available under Medicare and other insurance options. There's so many different insurance companies out there and so many different plans and so many different benefits and things like that. It's hard to answer questions about specific benefit programs, and it shouldn't be a surprise to you if you come in and have a consultation and feel like we both feel like this is something that you would benefit from and we want to move forward with that. We'll get all the cost information for you available up front, and we'll work on your behalf to work with your insurance company or Medicare or whatever it is to try and make it as reasonable for you as possible. It doesn't do either of us any good to have treatment options available that nobody can or wants to afford. So certainly we're going to do everything in our power to make it reasonable. And there are outside financial assistance options as well that we can go through on a case-by-case basis. So as we talked about earlier, it's proven there's about a 97% patient satisfaction rate, and interestingly, an even higher partner satisfaction rate with a three-piece device. It's proven to reduce the risk of infection with that antibiotic coating. It's typically affordable, it's typically long-lasting, almost 90% up in use after 10 years. And considering that, these are oftentimes placed in gentlemen in their 50s and 60s, I think that's pretty impressive. It's a natural, designed to maintain a natural appearance for sure in both the erect and the flaccid state, and doesn't typically interfere with other aspects of sexual function, including ejaculation or orgasms. And it's spontaneous. It's not like a pill where maybe the mood strikes you and your partner and you say, okay, well, give me 2.5 hours, and we'll be ready. So this can be more spontaneous, which I think is certainly ideal when it comes to sex and sexual function. Certainly, there are risks with any surgery, like we talked about earlier. Not all patients are candidates for penile implant. The biggest reason that I might turn somebody away, at least momentarily or temporarily, in our office is poorly controlled diabetes. If you have a very high hemoglobin A1C, it's not in your best interest to have that implant at that time. We'd work with you and try to get you to work with your primary care provider to lower your A1C so that we had an effective and safe procedure. Having a high A1C can double and triple your infection rate depending on how high your A1C is. So that's the biggest reason that we might ask somebody to work on their health before performing an implant surgery on them. We talked about earlier, there could be mechanical failure, although that tends to be fairly rare and up to a decade later. Certainly, we talked about risk of infection, certainly with diabetes, but also spinal cord injuries or open sores can cause a risk of infection. Pretty uncommon there. And again, at baseline, there's about a 1 or 2% risk of infection. So very rare. All right, so in summary, ED is very common, like we talked about earlier, up to 40% of men at age 40 and 70% of men at age 70. There are lots of different treatment options. We'd love to work with you to discuss the options that would be best for your personal situation. Here are, if you can put your camera over this square here, you'll be able to see the link to a quiz that will help you assess the severity of your ED. So another thing to look at. I'm going to pause there for just a second, and then we'll answer any questions.
All right. Thank you so much, Dr. Powell. We appreciate it. So as a reminder, if you have a question for Dr. Powell, you can write it in the chat box at the lower portion of your screen, and I will pitch those questions over to him for us to answer. And Dr. Powell, I'll just ask if you leave this up on the screen for the next couple minutes, if anyone who's joined us today would like to jot down your name and contact information, now's a good time to do that as well. So Dr. Powell, the first question, can I still orgasm after the implant?
Yes. For the vast majority of guys, it doesn't interfere with the other aspects of sexual function. So sensation, orgasm, ejaculation. There are certain previous conditions, like if you had a prostatectomy, your ejaculate is already gone, and that an implant is not going to improve that. But if you have the baseline ability to have an ejaculation and an orgasm, then yes, you'd still be able to do that after a penile implant.
Excellent. This is a good one. So I am 74. Am I too old to have the implant surgery?
No, I don't think so. It really depends on your overall health. I mean, I have some 74-year-olds that are extremely healthy and extremely active, and I would not be concerned about putting an implant in those patients. So it really, I think, depends on your overall health, less so on your age. But I think, 74 is not unheard of.
All right. Is there a vitamin or a drugstore option for treating my ED?
Like an over-the-counter option?
I'm guessing that's
okay.
What they're asking. Yeah.
Yeah. I mean, I think the short answer is no, and the long answer is that a lot of the over-the-counter